Morning. This is a UROWebinar. I am Maurizio Colecchia, the chair of Uropathology section of EAU. And in this webinar discussion address major issues related to the diagnosis and management of grade group 1 prostate cancer. The renaming of the term cancer has been proposed. The different management strategies for this cancer in various active surveillance protocols will be discussed. The renaming of grade group 1 has been proposed in the past, and it will be addressed from a multidisciplinary perspective, suggesting potential solution to avoid overtreatment. And the first presentation is from by Gladel Panner, a pathologist from the University of Chicago, and his presentation is renaming grade group 1 prostate cancer from a pathology perspective.
Thank you, Mauricio. Good day, everyone. And first, I would like to thank the European School of Urology and the EAU section of Uropathology for giving me this opportunity to speak. So I don't have any financial conflict of interest to report, but I would like to emphasize at this point that as a pathologist, I'm in support of renaming low-grade prostate cancer. So I'm in that minority group, and I just like to state this out because some of the viewpoints that I'm going to share is influenced by this stance, especially at the latter part of my talk. So, as already mentioned by Mauricio, currently there's this heightened debate on GG1 prostate cancer renaming, and there are multiple publications out there in the literature. And this is not a new topic. This topic, as we know, was already there at least 15 years ago. And recently it was brought up, especially with the publication of our paper in the JCO, and it just generated more discussions. So for the purpose of this talk, for the benefit of time, I'm not going to go over in details what's already been discussed, covered out there in the literature. I'm just going to point out some of the salient points. But most importantly, I just want to emphasize where we are and the potential direction that we will be heading to with this current debate. So the pros and cons for retaining cancer label in GG1 has been laid out, and there are multiple arguments, multiple counter arguments, but I like to point out the bolded ones. Those are the main reasons. The main reason for argument or for the reason for retaining cancer label in GG1 is that GG1 has the histologic features and also molecular features of cancer. Now, for the cons, it's really about the behavior of this tumor. These tumors are unable to metastasize if it is fewer, rarely extend of the prostate, so very indolent behaving. And this behavior leads to these complications due to overdiagnosis, and not only overtreatment, but as well as the other downstream negative effects of this overdiagnosis. If we look at the histologic features of GG1, as you can see there on the H&E, you can see that the glands are infiltrating. That's a histologic feature of cancer. You can see it's percolating in between this benign gland surrounding them. And this tumor does not have a basal cells. As you can see, there's one benign gland there staining brown. Those are the basal cells. And this is a requirement for us to call something as invasive. And it also has this capacity to invade nerves. So it has the histologic features of cancer. Now, if we focus on a pure Gleason pattern 3, which is basically the component patterns of GG1, and if we look at the Gleason pattern 3 in other higher grade tumors, as in this case, as you can see there, the Gleason pattern 3 in GG1, the Gleason pattern 3 in higher grade cancers, they are indistinguishable morphologically and immunotypically. Now, if we look at the molecular side of GG1, GG1 can harbor also molecular alterations that are present in high grade cancer. And as you can see in this study by Baca et al., you can see that the different genomic alterations in high-grade cancers is also present in some of these yellow GG1 tumors, including ETS fusion, which can be seen in about half of prostate cancer. Of course, the counter argument for this point is that molecular features of cancer can also be seen in dysplasia, borderline tumor, or low malignant tumors in other tumor examples. Also, two biomarkers can be pointed out here. One is P10, and my clinical colleague will actually talk more about the P10 in details. And the other marker here is BRCA1, 2, and ATM. And it shows that the carrier rates of pathogenic mutation of these three genes, or even BRCA2 alone in biopsies, is higher in those reclassified cases than those that are not reclassified during active surveillance. But an important point here is that the rates, though, are very low. As you can see there, it's only 3.8% for these three genes, and it's 1.6 for BRCA2. So these are the histologic and molecular evidences favoring into cancer diagnosis. But against this is the behavior of GG1. And we know now, and there are multiple studies shown there, some of these are large studies, that show that pure GG1 is really incapable of metastasis and causing death. And this favorable behavior of GG1 leads to healthcare problem of overdose diagnosis. So if we look at the reasons are different, right? They're not just one factor going opposite ways. There are two different factors, pathophysiologic, the other is behavior going into different direction. And this is the reason why that if we do surveys on opinion, the opinions is almost diametrically opposite between pathologists and clinicians. Our two major societies, ISOP and GUPS, conducted this survey, and it showed that 89% for the ISOP studies endorsed retaining GG1 as cancer. And GUPS has also a high number, 81 or close to 82%, opposed removing cancer for GG1. Interestingly, in the GUPS surveys of those who supported, about half supported the change for radical prostatectomy only, meaning that there's a need to have the tumor fully examined or fully visible. One thing that I like to point out here, though, because this surveys reflects the current status quo. There's no society levels discussion yet that occurred discussing the pros and cons and options, benefit or no benefit for renaming from the pathological perspective. Now, there's another survey here, more than 1,300, this time multidisciplinary physicians on reclassifying GG1. Interestingly, the urologists and radiation oncologists have the opposite views. There's more who support renaming, 49% for urologists and 45% for radiation oncologists. In the survey, the pathologists are still against, but lower in number at 61%. Now, everyone is familiar with this study by Toso and et al. On active surveillance of GG1 prostate cancer with long-term follow-up, more than 1,800 men on AS, the cohort with a median follow-up of 5 years. And they showed the 5, 10, 15 cumulative incidences of grade reclassification, and shows the percentage there, 21%, 30%, and 32%. And this type of tumors, it's important for you guys, for clinicians, to identify. And I'm sure that my clinical colleagues will talk about it. But for my part, I like to point out the group, in fact, the majority of tumors not even shown in this diagram. And these are the tumors that were not reclassified. They are followed. And interestingly, this tumor are clinically quiescent, even without active treatment. And they stay biologically inert, cancer, on 5 years, some are 10 years, and some maybe even 15 years of follow-up. And this is really where the paradox is, because these cancers, or quote-unquote cancers, were not treated. They stay there and they are just quiescent. And the question for pathologists like myself is, do we see this type of tumors? In my opinion, yes, we see them. we see them as incidental low-grade prostate tumors in pathology specimen. Like, for example, in radical prostatectomy, we usually just pay attention to the index tumor, but prostate cancer is oftentimes multifocal. In the background, you can see this small indolent, clinically insignificant tumors. Common in cystoprostatectomy for bladder cancer, also not uncommon in prostate autopsies, and even in TERP specimen, we see this incidental cancer. If you look at the incidence of prostate cancer here in the US alone, currently there are more than 3.5 million men who was diagnosed with prostate cancer, and majority, a big significant proportion are because of this small incidental prostate cancers. Now in biopsy, do we see this? Yes, of course, we see them in biopsy. And now the question for us is that, could we tell that this is indolent or not? From the biological standpoint, of course, we cannot, but we have criteria how to categorize this. And the best criteria that we're using right now is this criteria, the Epstein's criteria, the clinically insignificant criteria, which kind of predict that this will be biologically indolent if they are within the criteria. So last month, our two major societies put out this white paper on defining this indolent prostate cancer, and we're calling for a multidisciplinary approach. This is not basically on renaming GG1 prostate cancer, but it addressed the issue of overdiagnosis of indolent prostate cancer from the pathology perspective. And we have a definition of indolent prostate cancer. These are cancer with invasive histologic features that do not spread outside of the prostate, become symptomatic, or shorten a patient's life, with an important part there that it is left untreated. And we pointed out that this has considerable overlap with clinically insignificant prostate cancer, but it does not necessarily mean the same entity. And we pointed out that biopsy alone is insufficient for the identification of indolent prostate cancer, and we are calling or appealing for a multidisciplinary approach, at least for the discussion regarding this issue. So I like to go to some of the statements. I'm gonna point out the salient ones. I'm gonna breeze through to some for the benefit of time. So how to detect indolent prostate cancer? I already alluded to this. They are incidentals in cystoprostatectomy, in radical prostatectomy as the non-index tumors. Now the question is, can indolent prostate cancer be reliably detected at biopsy? A subset of GG1, as we know, can be upgraded to higher grade at RP, about 20%. So the answer here is no. Now, when it comes to the word reclassification on active surveillance, our opinion here is that they may represent a previously unsampled higher grade component, usually Gleason pattern 4, not needle, or it could be a progression of same tumor, and there's some studies that show that. Or this could be a de novo, a higher grade cancer that is separate from the initially biopsied tumor. Now, we cited a study here, which is a Danish study, that a very small subset of GG1 at biopsy are associated with prostate cancer specific mortality. We kind of admitted, though, that this study did not have a central review, and the number of prostate cancer specific mortality may be really, really low. But the point that we're making is that even if it is really, really low, death may still occur in a small, very, very small subset of GG1. Further, we also emphasize the higher inter-observer variation, especially when we're looking at a subset of Gleason pattern 4, the poorly differentiated or the poorly formed gland pattern. And as already alluded to, a subset of GG1 harbors molecular alteration in higher grade aggressive cancer, and racial disparities is also important for detection of indolent prostate cancer, especially the higher rate of aggressive disease here in the US for African Americans. So how can we improve our ability to correctly classify indolent prostate cancer? And in the paper, we brought up this histopathological definition. It's a kind of a cleaner definition. Besides GG1, there should be no equivocal Gleason pattern 3 or Gleason pattern 4. It should be free of that. There should be no stromal dysplasia, what we call the stromogenic cancer. And there should be no cribriform carcinoma, like intraductal carcinoma in that tumor. So this definition may capture this indolent prostate cancer, but it's not really defining it. Now, we also emphasize the stringency of the selection criteria for AS, and then novel biopsy approaches are also important to the detection of clinically insignificant prostate cancer. So further, we also emphasize that the determination of cancer aggressiveness in biopsies mapped to a particular prostate location hold great promise. And it means that the index tumors that we are describing may not always be representative of the actual tumor behavior. And tissue-based genomic classifier tests help in refining cancer risk stratification. We want to point out here, and this will be discussed with my clinical colleagues, that the biomarkers, when we're using this, they are generally modeled to distinguish the aggressive ones, the aggressive tumors. And on the other hand, there's no tissue-based biomarkers or tests currently that can positively identify this indolent prostate cancer. It's usually that they are negative, and then we exclude them. That's usually, but nothing that is positively identifying this. So what about this white paper and GG1 renaming? So the paper obviously did not address GG1 renaming, and most pathologists already referred in the survey are not in favor of renaming GG1 prostate cancer. But from my own personal point of view, there's a major shift here in that uropathology experts now accepts the existence of a non-cancerous behaving entity within our diagnosis of prostate cancer. An entity that, in my opinion, being pro renaming, can be potentially renamed. So let's go to the million-dollar question, the decade-long question. Is GG1 cancer or not? And we can see the issue here, that within the spectrum of GG1, yes, there's a subgroup there, or majority of them, they are indolent, and if we label them as cancer, they are overdiagnosed, resulting to complication. But there's also a smaller group there that can progress and can show these different features. And in my opinion, they're appropriate to be labeled as cancer. But right now, there's no way for us to distinguish this. And this goes back to the question, maybe we are really asking the wrong question here. Maybe we should try to reformulate our question. Maybe we should ask the question, is there a low-grade entity within prostate cancer that is renameable as cancer or not? And I'm highlighting this only the subgroup of indolent prostate cancer, if we can characterize this. And my answer to this question is yes, in theory. However, with our current diagnostics and technology, year 2025, we are incapable of accurately identifying indolent prostate tumors. The only way for us to know that they are definitely indolent is to monitor them, basically active surveillance. So where we are now, so 2 years ago, myself and another pro-renaming pathologist, Dr. Mingzhao, we put out 2 papers. And if we really push for a renaming at this point, if we really push for it, we can only offer a non-committal term on biopsy. We cannot commit it is, we can basically put out a non-committal, meaning it could be cancer, it could be not. But this cancer, like for example, in the example here, this is an extreme example where in 1 biopsy out of 12 has 1 small focus of GG1. And in this case, call it as something non-committal, like acinar neoplasm with a comment that this could be represented under sample carcinoma. And this terminology of neoplasm take out that risk of overtreatment. However, for the management side, we should keep the current risk stratification as guidance for management. And so this kind of case, it may be cancer, it may be not. So just say for the benefit of explanation, let's say that this patient got overtreated and the patient got radical prostatectomy. Now in radical prostatectomy, since this is already a fully examined tumor, we can put a commitment here of what the tumor is. In this case, the tumor turned out to be small. Maybe we can use the criteria for clinically insignificant disease and call this as an acinar neoplasm. And this is my last slide. I'll be happy to answer questions later on. Thank you.
Thank you, Gladel. Yes, the outstanding presentation is also worth of discussion with many questions that we be at the end of our webinar will be done in written choice or in live. And so that's the second lecture by Pasquale Rescigno. He is an oncologist from Translational and Clinical Research Institute in Newcastle University, Newcastle upon Tyne, UK. And the title is Clinical Implication of High PSA levels and Other Factors of Aggressiveness in Indolent Prostate Cancer.
Thank you, Maurizio, for the invitation. I want to thank you also the European School of Urology and the EAU for the invitation and for participating into this really interesting debate. So I hope you can see my slides. And I'll say it's quite difficult to speak after Gladel because he did a great, brilliant job in presenting what's what probably is still debatable. So if there are factors of aggressiveness for GG1 prostate cancer, definitely one of these factors is the PSA. But we'll also discuss, and I would like to discuss other factors that have been mentioned by Gladel a few minutes ago. So this is my disclosure slides. So as I said, we will discuss a bit PSA and how the PSA can influence or at least direct us deciding which are the GG1 cancer that behave more aggressively. But there are other factors, other molecular determinant or what we call as a biomarker like P10 and T53, or as Gladel said also about some BRCA. So when we look at the EU guidelines, it's really clear that the risk stratification for localized prostate cancer is based on the ISUP GG, and we can basically divide our patient, split our patient in low risk, intermediate risk, and high risk. And beside the GG group, what we have to consider for this patient is also the clinical T stage and the PSA. So if the ISUP group, for example, is 1, but and the PSA is less than 10, and clinically these tumors are T1 or 2A, then definitely these patients are low risk. What does mean? That these patients have risk of relapse or biochemical recurrence that is almost rare, so it's 3.5% of these patients will have biochemical relapse, and most of these patients will not have metastatic disease. Things change a little bit if beside the ISUP grade 1, this patient have a higher PSA. So if the PSA is between 10 or 20, or if the T is not a T1 or T2A, but is a T2B, in this case, our patient will fall into category of the intermediate risk that is split in favorable and unfavorable. So as long as the ISUP grade 1 there is a ISUP grade 1, we can say that the patient has still falls still into the favorable category, even though if is in the intermediate risk group. But beside the PSA, there are other things that we need to consider. So most of these patients are categorized based on a biopsy. So I decided to discuss this paper that was presented on Minerva Urology and Nephrology in 2018 because it's quite interesting. So these were patients. We are talking about quite a big group of patients, that 372 patients that will fall into category of the patient with low risk or intermediate, but or intermediate risk, but favorable, that underwent that underwent surveillance, but despite despite this, people basically having the chance to go under surveillance, they received a radical prostatectomy. So they then compare the histology from the biopsy with the histology coming from the radical prostatectomy, and what this study show is that up to 8% in 28% of the cases, so almost a third of this patient, the majority of which were falling into the Gleason's 6 score, were actually receiving an upgrading when the radical prostatectomy tissue was studied. And this because either the Gleason score was higher than in the biopsy, or because there was extraprostatic extension. So this tumor that were clinically less than a T2A were then becoming a pathological T3A because of the extraprostatic extension. So unfortunately, we can't trust our biopsy 100% because we know that almost in a third of the cases, the biopsy will underestimate what actually is the Gleason or the presence of extraprostatic extension. But beside the T, beside the PSA, as Gladal was saying, we need not to look at the biology of our cancer. And the biology of our cancer means looking at genomic aberration that this cancer can have. There are indeed some biomarkers that will associate it with more aggressive behavior, despite the cancer looking pretty much the same. And one of these biomarkers is PTEN. So that was mentioned by Gladel as well. But what is PTEN? So PTEN is a good protein because is a regulator of a pathway called the AKT, the P3CA and AKT pathway. That is a pathway that overlooks a lot of other pathways, basically in a cancer, in normal cell and in a cancer cell as well. One of these pathways is the cell growth, for example. So we start looking at PTEN and the importance of PTEN almost 10 years ago, starting from the metastatic CRPC setting, so in more advanced disease. And in more advanced disease, we have learned that up to a third, in some cases also up to 40% of our patients have PTEN aberration. And on the top of this, there are also cancer that present alteration in other key proteins of this pathway, like PIK3CA or AKT, around 10%. So quite a significant proportion in the advanced setting has alteration in this pathway that correlates with more aggressive behavior. But how can we relate these in the with the topic that we are discussing? How relevant is PTEN in the grade 1 or in cancers that have a Gleason score that is, for example, 6. So I want to present this data coming from this paper from UROWebinar published on prostate actually this year. So these were patients that were qualifying for active surveillance because they had a grade 1, because they had a low PSA, for example, or because they were up to a T2A. But then during the period of the surveillance at the rebiopsy, the rebiopsy was showing either higher Gleason or the PSA was increasing. So they went to study the PTEN expression of these cancers, and they show that overall in their cohort of patients, PTEN was expressed in 12.6%. So the loss of PTEN is slightly less than in the advanced setting that, as I told you before, is between 30 and 40% of the cases. But what is important is not just the proportion of the PTEN loss, but in a patient and so the cancer that had PTEN loss had 9.7-fold greater chance of upgrading compared to patients that were PTEN positive. So definitely we can say that PTEN is is one of the biomarkers that will show aggressive behavior even in prostate cancer from the group 1. But again, there is also a really another nice paper that was published recently, only in 2023, on 58 tissue samples, so other prostate cancer, another quite big prostate cancer cohort, for one of the biggest that I found, at least for this kind of study on P10. Where again, they saw that PTEN loss was found in 62.1% of the upgraded cases compared to the 27.6% of control. So again, PTEN seems to be associated also in this work with a more aggressive behavior. But that's not the only biomarker that could be associated with aggressiveness, even in the group 1 prostate cancer. Another biomarker of aggressiveness is, for example, P53. So again, P53 as a P10 is a regulator of the cell cycle of the cancer growth, and is deranged in a lot of cancers. So you can see in the top of these slides that the alteration of P53 is a really common event in almost all cancer, and is quite common in the advanced prostate cancer setting. About 50% of prostate cancer in the advanced stage present P53 alteration, while again, like for P10, only 10 to 20% of the cases of localized prostate cancer present alteration and dysregulation of the of P10 and of P53 and the pathway that is regulated by P53. As for P10, also for P53, there are now new data emerging showing how this is relevant and how this can be associated with a more aggressive behavior. This is another big case series presented on a scientific report a couple of years ago on 189 radical prostatectomy. Where a good chunk of this patient belong to the GG, so the group 1, and what they saw that again, P53 expression, although the expression of P53 is not commonly tested, but I mean, at least they did this for this work, a P53 expression of more than 5% was associated with a higher pathological T stage, higher grade group, and with lymphovascular invasion. But more importantly, a P53 expression of more than 5% was also associated with a shorter disease metastatic-free survival. So patients that had higher expression of P53 basically had a higher chance to develop metastatic disease compared to other cancer. And with this, I want to thank you all, showing a nice picture of Newcastle in one of the few days of sun that we have during the year. Thank you.
Thank you, Pasquale. Outstanding presentation. Now is the time to present you Giorgio Gandaglia, a neurologist from Santa Fede University Hospital. He is also assistant editor of European Neurology. He is a Crystal Matul Award of European Society of Urology, and also author of Prostate Cancer Guidelines from since 2020. He is particularly involved in the protocol for active surveillance in our hospital, and this is the issue that we will debate with in his presentation, active surveillance in grade group 1 prostate cancer.
So thank you for this kind invitation, and you should see my slides now. And I'm honored to be here and to be part of this webinar. Today we will discuss about the management of patients with grade group 1 prostate cancer, and we heard about the biology of the disease and about what we should be worried when we have a patient with a prostate cancer and the diagnosis of grade group 1 disease. And we will discuss about the optimal management of these cases. This is my COI. I have no potential conflicts of interest to report. And first of all, we should focus on what is active surveillance. And when we talk about active surveillance, we are mainly talking about an approach which has the aim to cure our patients. So we are focusing on men with life expectancy, which is higher than 10 years, and the aim is to minimize the treatment-related toxicity without missing the window of curability, meaning that our patients are regularly followed up with schemes which are based on PSA, DRE, MRI now, and biopsy as well. And we decide when to treat the patient based on the triggers of progression, which we can observe actually during the follow-up. And it is completely different compared to watchful waiting, which is something palliative where we are not actively following up our patients, but we are just waiting for the development of symptoms related to metastases. This is a very nice slide, and it's a recently published study in European Urology Oncology. And here you can see that it summarizes the widespread diffusion of active surveillance over the last few years. And we started with PSA and DRE, and then novel biomarkers emerged. And now we have MRI, PSMA, PET, genomics. And you can see also how guidelines changed and how guidelines are now including active surveillance. And for the EAU guidelines, our guidelines, active surveillance has been recommended since 2010, more or less. And these are the main studies, the Loriclot series, the PRIAS, which is European, and we have obviously also data coming from the PROTECT trial, which are supporting in a way active surveillance, even if patients included in the PROTECT trial were managed with active monitoring. Historically, the concept was that we had to strictly select our patients. So we are talking about grade group 1 disease, and we had to select these patients based on strict criteria. You can see that we have different criteria such as the MSKCC, the PRIAS, John Hopkins, or we have the Royal Marsden or the Sunnybrook. And these criteria mainly, all of them focused on men with low or favorable intermediate risk prostate cancer, so with 3+4 disease, with a small number of positive cores and with a low PSA density and a small percentage of core involved. And we will see that now this changed and we are now using broader criteria. And this is the PRIAS. And as I was mentioning, for active surveillance, we need to follow up closely our patients, and you can see that the concept is that patients receive regular testing with PSA, DRE, and MRI plus targeted biopsy and concomitant systematic biopsy at selected time points. And there are triggers for a repeated biopsy earlier, such as a progression at MRI, and we will discuss it in a second, and also the presence of rising PSA or suspicious lesions at DRE, which are uncommon in patients with grade group 1 prostate cancer managed with active surveillance. This is what we typically do at our center, and we typically perform a pre-diagnosis MRI. And the concept here is that if we perform an MRI to diagnose prostate cancer, theoretically, we should dramatically reduce the number of grade group 1 prostate cancers which are diagnosed, and at the same time reduce the number of patients who are eligible for active surveillance, because we know that MRI typically overlooks grade group 1 disease. At the same time, we still have patients with grade group 1 prostate cancer. At our center, our prospective database includes every year around 150 new patients. And patients receive a pre-diagnosis MRI, and they can get also an MRI if it was not done before, after diagnosis. And then we have at 1 year follow-up, the MRI-informed confirmatory biopsy. So the patient typically receive an MRI at 1 year, followed by an MRI-targeted confirmatory biopsy. And then the follow-up strategy is based on MRI every 12 to 18 months and follow-up biopsies every 2 to 3 years. And we can anticipate, obviously, follow-up biopsies if the MRI shows something. And we typically perform MRIs which are evaluated using the precise score, for example. Why do we need confirmatory biopsies, and why do we need biopsies in patients who are selected for active surveillance or who have a negative MRI and who do not progress during the follow-up based on imaging? And here we see that even when we have patients with negative MRI, the proportion of patients with clinically significant prostate cancer diagnosed at follow-up biopsy is still substantial. And our guidelines recommend the use of MRI for active surveillance selection. So perform MRI before a confirmatory biopsy if you did not perform it before the initial biopsy. We should consider targeted and periregional biopsy course when we are doing a confirmatory or repeated biopsy. And we basically should not avoid confirmatory biopsies. So remember that confirmatory biopsies typically at 1 year are recommended and should be performed even if the MRI is negative or showing a stable lesion, a precise 3. We also know that the grade group 2 prostate cancer, we detect a confirmatory biopsy typically is not as aggressive as patients who receive immediate radical prostatectomy. So when we are treating our patients with radical prostatectomy upfront for a grade group disease, or when we are treating patients with radical prostatectomy for a grade group disease who progressed after a grade group 1 disease was detected during active surveillance, typically we're treating patients with a more favorable profile. And remember also that we should consider long-term biopsies at follow-up. So we have seen the PRIAS and the other follow-up strategies, and they still rely on the use of confirmatory biopsies at 1 year and then follow-up biopsies at 3, 6, and every 3 years, basically. And even when we perform a confirmatory biopsy informed by MRI, reclassification is still relatively high and higher than 10%. And these are great data coming from the Memorial Sloan Kettering and showing that patients with a negative MRI should not avoid or should not refuse at least a biopsy. And even if we have a negative baseline MRI, the risk of having a disease progression can be as high as 30%. So 1 out of 3 of the patients with stable MRI scores or a negative MRI have a clinically significant prostate cancer at a follow-up biopsy. This was confirmed also in this very nicely written systematic review of the literature and meta-analysis, as you can see here. And avoiding biopsies in men without progression at MRI would cost missing approximately 30%, so virtually the same number compared to the MSKCC study of men with histological progression. And this is another trial recently published in European Urology Open Science, confirming that even if we have a negative MRI, we still have a substantial rate of histopathologic progression. On the other hand, we should remember that the adherence to long-term surveillance biopsies is still low, and the tendency of our colleagues, we as urologists, and of patients is to rely a lot on follow-up MRIs and use them to reduce the use of biopsies during follow-up. Let's have a look at the outcomes of active surveillance. And actually, when we are talking about longer-term outcomes, these patients are typically men who were managed in the pre-MRI era and when biomarkers were not available. And now this changed completely. And you can see that the changes in the treatment and the diagnostic paradigm of prostate cancer patients resulted in improved treatment-free survival, as you can see in these graphs. And here you can see that basically in low-risk patients, even if the risk of metastasis was lower in all the decades evaluated for patients who were included in this study from the Netherlands, the risk of treatment and the treatment-free survival rate was lower for patients managed earlier, so in the earlier 2000s, compared to those treated in the recent years. And here you can see again the role of the long-term follow-up and what can happen when we treat our patients and we decide to perform a biopsy based on MRI only. So this is a study from the UK, UCLH, and you can see that patients were basically stratified according to the initial grade group, and so the Gleason basically, and the presence of a visible or non-visible lesion. And then patients received a biopsy only if they had a progression at MRI. And here you can see that the worst outcomes were observed in men with a grade group 2 disease and visible lesions, while patients with a grade group 1 disease and non-visible lesion were the ones with better failure-free survival and time to prostate cancer treatment. At the same time, when we look at the follow-up based on biopsy, and this is a US cohort, USA cohort, we can see that basically there are patients experiencing any reclassification in 50% of the times, but at the same time, we have a very low metastasis-free survival rate, which is substantially lower than the all-cause mortality. And here you can see again the GAP3 data and the UCSF, where metastases in pure grade group 1 disease, as it was described earlier, are very rare events. And basically, we can expect metastasis mainly in misdiagnosed grade group 2 or higher prostate cancer patients. And finally, and this is my last slide, here you can see which are the priorities for healthcare professionals in the management of prostate cancer patients when we're talking about active surveillance. And here you can see that we should understand how to personalize active surveillance. We need novel biomarkers. We need to better define the role of MRI, the use of targeted and systematic biopsies, and we need, obviously, improve the role of histopathology, including the incorporation of new modification to the grading system and new approaches to biopsies. And with this, I'd like to thank you for your attention.
Thank you, Giorgio, for this wonderful presentation. And now I start the discussion, including all of the speakers, Gladel, Pasquale, and Giorgio. And there are many questions about histopathology features of grade group 1 tumors. And I read someone for the audience, and the definition of grade group 1 is 3+3 Gleason score, definitively, while another member of EAU, Hossein Roshani, report a very important questions that definitively address our competence about to share the indolent tumor respecting the aggressive tumor, the intraductal carcinoma issue, and also the modality to report cribriform carcinoma and intraductal carcinoma in grade group 1 or 2 tumors. Gladel, you would suggest any other consideration, or otherwise I read the answer?
Yeah, I just like to expound a bit on that clarification. I think there's right now there's kind of confusion. I think part of the reason, as you know, Mauricio, is also because of the divergent recommendations from our side coming from the pathologists in this. So the question here is that GG1, when you say GG1, does it has intraductal carcinoma or not when we say GG1? And the answer, unfortunately, right now is yes and no, because of this divergent differentiation. Yes, in the point that when we have GG1 cancer and we have IDC, one recommendation from one of our societies not to incorporate, not to include IDC, basically excluding IDC in the GG1 cancer. So in our report, we will still be reporting GG1 and IDC. That's the recommendation of GOPS, one of our major society. However, the recommendation of ISO, when we have GG1 cancer plus IDC, is to include IDC into the grading. So once you have IDC, that's no longer GG1 by definition because of the architectural pattern. So if we have GG1 plus IDC, that will be at least GG2 and above. So by ISO definition, you cannot have GG1 with IDC, but by GOPS recommendation, you can have GG1 plus IDC reported separately. I hope it's clear enough. But the good news is that, and Maurice is also part of this, we are sorting this issue out at the moment, and hopefully before the end of the year, we can have a joint recommendation, not divergent one.
Yes, and another similar question is, can Gleason 3 have cribriform or intraductal components by definition? The answer is probably yes, but it's a very rare event. And in our experience, I consider that the experience also in Chicago is similar. There are very few cases, well-documented cases in the literature, where we have a true indolent 3+3 and only one small focus of intraductal carcinoma, because the intraductal pure carcinoma is very rare.
I just like to have a point of clarification for our urologist, Mauricio. When we're speaking about cribriform means a pattern. So cribriform can also be intraductal, or it can also be invasive cribriform. And the way to distinguish the two is by morphology, by identification of basal cells in intraductal carcinoma. But sometimes it's actually difficult to do based on H&E. And in fact, some recommendation for us, like in the ICCR recommendation, is actually just to lump this together, because they are bad patterns anyway. They are bad prognostic patterns. You just lump this, although we can separate it occasionally by morphology.
Thanks for this important feature of the cribriform pattern, that is more than a pattern, because cribriform is a morphological feature. And so we have no possibility to understand completely the meaning of cribriform if we have no experience about the correlation, clinical pathological correlation. And so we have a distinction among a typical proliferation that is similar to the ex in situ cribriform carcinoma, that we call it AIP, and the cribriform pattern in invasive carcinoma are very distinctive features in different cancers. And I have a question for Giorgio. Is about your experience after the introduction of multiparametric magnetic resonance, because in how many cases you have seen that in grade group 1 cancer, the target area is with a more aggressive feature respect than the standard biopsy. So, in my experience, there is the possibility that standard biopsy outside the target area could have aggressive features of cancer.
Yeah, it's nowadays relatively uncommon but possible. The concept which is now popularized and let's say taking space in the urological communities to consider only visible lesions, so MRI detected cancers, and to kind of forget about what is not visible, because this is the first biomarker for tumor aggressiveness. At the same time, we know that between 5 to 15% of patients actually harbor concomitant clinically significant prostate cancer. It's rare to have a clinically significant prostate cancer which is driving the prognosis of our patients outside of the MRI visible area. And that's why our guidelines now recommend to perform MRI targeted plus perilesional biopsy. And the concept is that during the biopsy, we could miss the targeted area, particularly when it is very small, and doing a perilesional biopsy can increase the chance of detecting the tumor, which is seen by MRI but missed because of technical issues. But from let's say a diagnostic standpoint, this is the answer. From a clinical standpoint, a surgeon's view, my answer is also that knowing that you have a clinically significant prostate cancer at the contralateral area of the prostate, in the contralateral lobe, can drive your decision to perform a nerve-sparing approach to treat the patient with a focal therapy. And it is very important. And we know that having a clinically significant prostate cancer outside of the index lesion is relatively common at the end.
Thank you, Giorgio, for this clear answer. Then for Pasquale, you have highlighted the importance of P10. P10 is studied since 2005, and there are a lot of studies also by immunohistochemistry, then by a molecular approach to observe the presence or loss of P10 in indolent prostate cancer. And you have said that there are important clinical implications, because when there is a P10 loss, there is urgency to focus the follow-up of the patients. But in my opinion, in 20 years, we have studied this molecular finding, but now we have not incorporated it in any recommendation for active surveillance protocol, or also generally for the follow-up of the patients. There is an answer to that question that is very strange.
It's a great question. The problem is that the majority of these data come from retrospective studies. So there are not clinical trials designed to show the clinical relevance of this alteration, especially in the localized setting. So until we do or we design something like this, it will be really difficult to incorporate this biomarker in our clinical practice. Although I believe that this is extremely, especially for P10, is an extremely important pathway in prostate cancer, because we know from the advanced setting, that this is a and there are even a lot of preclinical data that show that how PTEN is important for the development of the metastatic disease. And now there are also new targeting agent targeting this pathway. So there are AKT inhibitors, there are P3CA inhibitors that will become available in the advanced setting. So it's possible that that can be used in an early setting, both in the metastatic or in the localized disease.
Thank you. Probably we have the time only to answer some questions from the audience, and I incorporate two ones for Giorgio. Ahmad Osama Mohamed say, for active surveillance, if MRI is satisfactory and no change, would you still biopsy? The first one. And given that, Matteo Droghetti say, ask, given that MRI invisible disease on MRI have a similar prognosis for ISUP1 and ISUP2, grade group 1 and grade group 2, do you believe there might be still room for systematic biopsy in active surveillance protocols? Probably you have
in
just answered.
2025, yes, I believe we should still biopsy even if we have a negative MRI or an MRI showing no progression. But in the future, we should, when we talk about MRI, we should discuss about the quality of MRI, which is the same as the quality of the prostate biopsy and the pathologist. So if you have an excellent MRI done by an excellent or read by an excellent uroradiologist, I would probably consider also skipping a biopsy. But the reality is that in the real life practice, you get MRIs from everywhere in Italy, at least at our center, and the quality is not always optimal. So, and I agree also with regards to the systematic biopsy. Now the guidelines are recommending periregional biopsies. So the concept that what you don't see is harmful is kind of, let's see, changing in recent years.
Thank you. There are many other questions, but probably the only one finally is from Julian Mitzik. How assessment according to precise score impacts decision on biopsy? Will you skip a biopsy in precise 1 or 2?
You can reduce the biopsy intensity, but I typically tend, particularly in young patients, to consider a biopsy, even if the precise is 1 or 2. But obviously, you don't tell your patient do it exactly at 1 year, maybe, or exactly, but you can reduce the frequency.
Thank you, Gladel, Giorgio, and Pasquale. I am very satisfied for the participation, also the audience that have not stopped the video after and are all in with us until the end of this webinar. And see you for the next webinars in EAU program. Thank you so much.
Thank you. See you.
Thank you.